So today's topic is we have two topics today. Okay, we have lung abscess, we have tuberculosis, and I'm just telling you, like today morning itself, we had this discussion regarding your university exams, which might be expected in January. Okay, so be prepared accordingly. And these, not lung abscess but tuberculosis, yes, will be a definite question. Lung abscess may be a short answer. So lung abscess में ज़्यादा detail में इसलिए नहीं बता रही हूँ. I'm not telling because last class when I was telling you, yeah, come in. आजा आजा, come. Just sit here only because I'll know that your roll numbers have not been taken. Just sit with him. Okay. So lung abscess, I'm not telling in much detail, or I'm not telling rather because last class when I was taking pneumonia, there I had told you about it. So that is the same pathogenesis, जो pneumonia का था, if you have seen through the same organisms. The only thing is that when pneumonia is not treated, it goes for abscess. So you have to just add on that statement. The pathogenesis, the etiology, everything remains same. The complications are also same. Lung abscess, they usually ask you about the pathogenesis, how it is happening. So that's all you are supposed to know. So today we'll go into tuberculosis. Tuberculosis is something which you will face in your entire career, like pneumonia again. B now, B later, B you do your MD, MCH, Masters. So the specialty, anything, until unless you go out to states or something. There also, if there is Indian population, there is chance that you have to know about tuberculosis. Fine. So most of it, all of you must be already knowing, like the bacilli which is causing it and all that thing. The things which you have to know as such is the pathogenesis, which is bit tricky. वो याद नहीं रहता easily. And apart from that, in community medicine, the RNTCP guidelines and all that, that you have to mug it up. So these are the most common things. So what is tuberculosis? We'll just go in brief a bit. So it's a chronic pulmonary disease, okay? It's a chronic disease. It's not a acute problem. It's a chronic disease, and it can both present as pulmonary and it can as well present as a systemic disease. Fine. So tuberculosis can happen anywhere in the body from head to toe. It can be in the brain, it can be in the chest, stomach, intestine, anywhere, even on the skin, it can happen. So you have to be aware of this disease very much. The bacteria which we know is Mycobacterium tuberculosis, but there are many more resistant species by now. I'll be telling you in some time. Okay. So that's what I was telling. It's a potentially contagious disease. And what does basically tuberculosis, the term, means? A tubercle is something like a round or a swelling thing on your body. Wherever you find a swelling, you can call it a tubercle. And osis is nothing but the disease or the condition. Now this is a world map. So all you have to focus is wherever it is deep pink, those are the high incidence places of TB. And wherever it is blue or even lighter shade, those are the low incidence places. So as you can see, India definitely has the highest incidence, okay? And the rest of it is in Africa. Fine. So how is it transmitted? All of us know by now it is person-to-person transmission by cough droplets, by usually by the sputum or the cough. Okay, that's the most common way of transmission. Nowadays, this disease is not a burden, but when it was actually a nightmare, you know, people used to die of like TB. If I'm not sure if you guys are aware of it or not, but even Swami Vivekananda had like TB and he died of that. So though it was so dreaded, there was no treatment then. Now we have a lot of treatment, but the thing is, despite of treatment, we have so many drug-resistant species that it is just a long-term disease. It's a burden on the population. Fine. So okay. So presence of the bacteria in the body is tuberculosis. It can be just the bacteria is present. It is not doing any disease. That is known as the latent form. Okay, latency is a term used for any organism which is in your body, but it is not causing a disease. It is just waiting for the correct time to come, and then the disease will happen. That is what is latency. Something, the organism is there and you're having symptoms, your body is throwing symptoms, that is known as the active form. So latency is most commonly seen in cases of viral diseases like herpes zoster and all those. I don't know how many of you had chickenpox in your childhood. Anyone who had chickenpox? Some of you. Okay. So chickenpox, the virus never goes out of the body, okay? It stays in the nerves root, in the dorsal root ganglion, it stays there. And it is waiting if you are having any stressors. Like if it is female, they can have, if during pregnancy it can be an outburst. If it is male, due to smoking, alcohol, or just simple stress. You take stress for your exams, you can just have a break of that chickenpox virus which was sitting all the while from your childhood. Okay, so similarly, tuberculosis also has latency. Fine. Okay, so these are the bacilli I was talking about. It is the entire list of it. You need not know all of them. Just 1 second. It changed there? It didn't change here. Okay, fine. So this one is the Mycobacterium avium complex. One you know about Mycobacterium tuberculosis. Next organism which can cause tuberculosis is MAC complex, the MAC. Now it has got three separate bacilli in it. One is the avium, one is intracellular, and one is the chimera. Fine, these are the three ones you are supposed to know. Even in microbiology you must be knowing. So that is the MAC complex you are supposed to know. Then next one will be, just a moment. Okay, whatever, no issues. I'll teach from there. Fine. So this is the list which you are supposed to know. You know the M. tuberculosis, you know the MAC, and yes, yes, please. Sit here only, sit here, in this first row. Okay, and M. bovis, Mycobacterium bovis also you are supposed to know when you are writing the etiologic causes of tuberculosis. So Mycobacterium bovis is the one which is seen in, come, in the first row. Okay. Mycobacterium bovis is the one which is present in cow. So it is transmitted by milk, cow milk, which is the most common, thing which everybody takes from childhood to elder age group. M. leprae, you don't have to know, it is for leprosy. So whenever you are asked what are the organisms which cause tuberculosis, M. tuberculosis, MAC, M. bovis, these are the names you are supposed to write down. Fine. So a bit of microbiology which all of you are supposed to know. No need to know all of it. All you have to write here is this one, okay? It is an intracellular pathogen, okay? This pathogen dwells inside the cells. So it is intracellular. And second, it is obligate human pathogen, okay? It's a obligate bacteria. Without human beings it cannot survive. So obligate, intracellular, two things you're supposed to write, and how it looks. It looks like a rod. This is the thing. So these three things you are supposed to know when it comes to this bacilli. Okay, other things are not much required. Now we classify tuberculosis. How do you classify it? One is the pulmonary, as I have told you. This is the most severest form, or you can say most common form, which we get to see in our day-to-day practice, and the transmission is also very easy. Rest of the forms, the extrapulmonary ones, are something which is transmitted from the lungs or sometimes by direct contact. That is very, very rare, doesn't happen. Extrapulmonary is more of from the lungs only. It is because of the hematogenous spread or via the lymph nodes, it is spread to other parts of the body. Okay, but still direct inoculation can happen. Like in skeletal TB, it can directly be that the tubercle bacilli sat on the bone, in femur bone or chest bone, somewhere like that. Okay, so these are the other places. You can, if you don't remember this list, you don't have to mug it up. Just remember to write any of the common body parts. Most commonly, write in intestine, in bone, okay, in brain. These are the most common parts. And do not forget to mention HIV, okay, because it's the most common one. So one is pulmonary, one is extrapulmonary. Common places where it can happen: bone, skeletal tissue or bone, intestine, brain, for that matter lymph node, and HIV associated. 5 will do, okay. So this is the pathogenesis. Rather than putting up a flowchart, I just thought to discuss it off like this. So first of all, the first step which happens is there will be entry of the bacilli, definitely, either by the cough or the sputum. It enters your system. Once it enters your system, it will go and, as I told you, it is intracellular. It will go and sit inside the cell. Let's assume alveoli. For now, it's in the lungs. So it goes and sits inside the alveoli. And there it will start replicating itself, it will multiply. Once it is multiplying, it will activate the innate immunity response, okay? The one with you are born, not the other one, the acquired one, the innate immunity. So your cell mediated and your antibody mediated, both of them will get activated. So once the cell mediated is activated, T helper cell 1s are the ones which are working here. So all you have to remember is T helper cell 1. Rest of the things, of course, it is same for all the pathogens. T helper cell 1s are coming. Once they come, they activate the monocyte macrophage system. Macrophages will come. They will go to the alveoli. They will start eating up the alveoli and the bacilli. Okay. In this process, what they do is they will liberate the bacilli out. They will cause caseous necrosis. Necrotic material will, because the alveoli are dying. When the alveoli is dying, everything will be like, necrotic, and everything will be dead over there. So necrosis will start. Now this tuberculosis will not go only by macrophage activity. It has to go, something more higher is needed. So they will start, these macrophages will be like, we will make an army. Single person, we cannot do it. So multiple macrophages will come together and they will make what is a giant cell. Okay, like singly you are going somewhere and somebody is torturing you. 4, 5 of you go and hit them. So that is like an army. So that is what macrophages become. They become giant cell. The most common giant cell which we see here, which you have to name, is Langhans giant cell. Okay, Langhans giant cell. This is also your slide. Okay, my histopathology slide in your Viva. So remember these terms: Just tell these terms. Last class also, I don't know to whomever I took the practical, I was telling them how to identify in the lymph node and how to understand that. So those are the same terminologies. You have to tell a granuloma, and that I'll come eventually. This is the pathogenesis part. So there only I'll tell. Let's just wait. So I'll just explain the last bit, granulomatous inflammation lastly. But pathogenesis, macrophage, the bacilli enters, bacilli multiplies, innate immunity activated, T helper 1 comes, they create macrophages, then they make giant cells. And then what forms is a granulomatous lesion. This host susceptibility to disease is something part of the pathogenesis. It's not in the flow chart, but it is up to you. See, if your immunity is good, then usually the chances of such a severe infection is not there. It will be killed and it's done. But if your immunity is low, like somebody in HIV patients or immunocompromised who are having a renal donation or something, their immunity is less. So they cannot form these macrophages as well. That is what we mean by low immunity. Maybe sometimes even the innate immunity will not be activated at all, especially in HIV patients. They don't have immunity left. So nothing is going to get activated, only the bacilli will be sitting all the time and it will create the infection. So that is what is host susceptibility to the disease. Okay, fine. So then we come to the pathological findings. This is from Robbins only, no need to take any pictures for as such. So then after this, after the pathogenesis, they will ask you to write the morphology of tuberculosis. So in that you have to write the gross and the microscopy. Grossly, okay, let's begin from here. Grossly, first of all, when the first, what I was telling, the bacilli comes and multiplies, so in that phase it will form something called as the primary complex. So there are definitions to these primary complex and all. I have not mentioned here because as per the new syllabus you need not know the definitions, but you can just go back to your book and read, because many of the examiners who come, they are actually in the older generation and they have been asking that. So you're supposed to know this. So during your viva you remember them. In theory I don't think you'll be asked much about it. But whenever, if there is a term called primary complex, just write about this, that the bacilli have come, and in especially they make place in the upper lobes of the lung. Okay, why? Because upper lobes of the lung are most aerated and they are a bit cooler compared to the lower layers. So this Mycobacterium tuberculosis needs a bit cooler place and a humid place. So upper lobes are the best places for them to accommodate, but they can be anywhere in the lung, not necessarily lung. So they will form the primary complex, which will be nothing but a caseous necrosis and something like a small tubercular swelling on the lung. Then after that it will, if the infection is not curbed down here, it will be going to progressive tuberculosis. Okay, so it can just expand in the lung anywhere. Okay, if here also it is not, treated or suppressed or anything, it will spread by the blood route and it will go to any organ like liver or spleen or bones or anywhere. It can just go and it will form what is called as the miliary TB. I'll tell you about it. Just wait for it. I'll tell what is miliary TB. Say here in primary complex only, it is something has gone wrong and it has been healed. So there will be just a scar left. Okay. If it is not healed, the immunity was so active that it just killed the bacilli, but some of the bacilli have stayed back. Then that is what is latency I was telling you some time back. They will be just sitting. When the time is right, they will come back when the immunity is low. Okay, so these latent infections will lead to reactivation. That's what I was telling you, that they are sitting quiet whenever required if they come back. So that is your secondary tuberculosis. Fine, secondary tuberculosis is nothing but there was a primary focus, the immunity acted, they slept, they are not doing anything, later on they got activated. So that is secondary tuberculosis. Okay, secondary can happen in the lungs or it can be in any other organ also, doesn't matter. So so there are just 2-3 terms you should know. One is the primary complex, one is the secondary tuberculosis, one is latent infection, and last one is miliary TB. So I'll tell you, just show pictures of them and you'll understand. So this is a regular TB we are talking about. In chest X-ray you will see something like this. This is usually known as the Ghon's focus or the primary complex. Ghon was a scientist who did it, so it's on his name. And the definition you'll find the book. This is how grossly, we don't get such a huge segment nowadays at all, because first of all we put patients on AKT. But still, if it comes, it will look like this. Okay, so this is what I was trying to show you in the slides the other day. Anything circular. Okay, anywhere you're seeing, first of all though, you should identify the normal organ, as I've always told you in all your practical classes. Still, if you're not able to get that, if you're getting these kind of multiple circle areas like this, okay, the cursor is not working here. So multiple circle areas, these are nothing but granulomas. Okay, when you take, this is in the low power, when you take a higher power, See, you can see in the field, everything is pink towards that side. As if there is no structure, everything is destroyed. So that is nothing but it's the necrosis part. Wherever you are seeing towards your, this will be your right. So towards the right, if you are seeing there are lymphocytes here, there is some structure left, and this lining is the alveoli. Whatever, whatever will be like lifeless, that is the necrotic part. It is, I don't know, to some of the people I had explained in practical class that necrosis is nothing but homogeneous eosinophilic lifeless structure. Okay, so that's what you are supposed to say, and that's what you are seeing here. And this is just a high power of showing you the horseshoe shaped giant cell. It, just look at it, it looks like a half garland or a horseshoe, and that is what is named as Langhans giant cell. So if you remember the term, tell it over there, you get an extra mark. Okay, Langhans giant cell. So this is what is tuberculosis. This is what a granuloma is. These are small multiple granulomas, all the circle. This is one entire granuloma, and this is the Langhans giant cell. Okay, I'll just explain the granuloma again. Inside it is the caseous necrosis. These are the alveoli cells. Outside is the lymphocytes, and those are the giant cells. Epithelioid cells are okay. Cells which are looking like bit of flat. Those are the epithelioid cells. Okay. So this is your granuloma. Now this is AFB stain. Whenever we receive any sample labeled or suspected of tuberculosis, be it in a fluid, be it histology, we always do an AFB stain. Okay. Sometimes we may not get these giant cells anything, so this stain is important for us. So when we do a stain, whatever the caseous necrosis part I was showing you there, or sometimes if we get a macrophage inside that, we will, because I told you it is intracellular. So inside that we get to see these pink color structures, whatever you are seeing. These are all nothing but rods. So we describe them as pink rods. That's what I was telling you some time back, to just remember that, you know, that in the initial slide key, just remember it is obligate parasite, it is intracellular, and this is how it looks. So this one is the rods. Okay, so now secondary tuberculosis. As I was telling you already, that secondary tuberculosis is nothing but once the infection is latent and after that it reoccurs, it is known as secondary tuberculosis. So that is what it is written over there. It can take, again, the time frame is not fixed, as I was telling you. It may happen that in lifetime, it may never happen. It may happen that just after a few months of latency it will happen. It can take years to happen. So we do not know the time frame. Usual places, bilateral lungs or the upper lobes as usual, and this hypersensitivity reaction and all is not required. Yeah, there is one point which you should remember, that in secondary tuberculosis, lymph nodes are usually spared. Why? Because in the primary infection already lymph nodes has been sensitized and they were active. They have curbed down the infection. So there is less chances that secondary tuberculosis, the lymph nodes will be involved. So what we do clinically, I have not told the clinical part because it's not required here, but usually when a patient is suspected of tuberculosis, clinically we palpate the cervical group of lymph nodes. So you feel that mated. You will go down to your clinicals and you will see, you can actually feel these group of lymph nodes. Right now you might not be feeling, if you try to palpate yourself, you will not feel anything. But we literally feel it like a swelling. Okay, and there will be multiple swelling. The lymph nodes tend to aggregate together, that is known as mating. So they will be a mated group of lymph nodes, that is most common characteristic. So that's why we are talking about this lymph node in secondary tuberculosis. Okay. It's the same thing. Histologically, the rest of it, everything is same. Gross appearance will be same. There will be granulomas. Everything else is same. Nothing much to know. Okay. Before this, I would like to show this miliary ones. Okay. So miliary tuberculosis, as I was talking, I think we don't need this part. Okay. This is all you are supposed to see. As we have seen the pathogenesis, miliary tuberculosis is happening when the primary infection was not treated appropriately. The infection travels by hematogenous route. It can go to any organ. Right now the example is of lungs. So it is called so because we have this dal which is millets. It's very small pinpoint type of dal. Maybe it's moong dal if I'm not wrong, but millets are themselves a cereal also. So they look like that. So that is how your organ which is affected will appear. On the surface there will be many tiny tubercles present. So that is what is the miliary tuberculosis. It is happening how I told you. Rest of the features are all same. Only thing, grossly you have to write there are many tiny tubercles. That's it. Microscopy same, granuloma formation, all that, whatever history is there. Okay. 1 second. Okay. Now, after all these things, the most common question asked you will be lab diagnosis of tuberculosis, or it will be just a part of the question. So, in that, details of this question will come when you will be in medicine. Here, most of pathology will be asked, but still, you should know the name of the test. So, the first one will be a tuberculin skin test. This is kind of now obsolete, but still, in primary health centers and all, this is the test which is done because other facilities are not much there. Okay, so what we do is we have a PPD, purified protein derivative, that's the name of it, and that is injected somewhere on the forearm, and wherever you inject it, you take a pen and you mark a circle around it, a small circle, and then you ask the patient to come back after 3 days of the inoculation. If there is induration which is beyond the circle, we measure it actually from the site of injection. We measure it, how much is the diameter. It's usually in millimeters. So if it is like more than 3 millimeter, it's a dicey thing. More than 5 millimeters, it's a positive test for tuberculosis. Okay, that time it used to be that. Nowadays, with that also, then we go to the next step, and we either do an AFB, which I had already shown you, or we just take the sputum and suspend it for cultures. Or we, okay, culture is this one. This one is the one which does culture as well as genetic testing. So nowadays we have gone to the genetic level. We just put it in assay, but these tests are a bit costlier. So for the regular patients, no. Still, this is the test. Apart from this genetic testing, we have the fluorescent microscope where we stain it, and we can see it is auramine rhodamine stain. Okay, it's there in your textbooks. Don't worry. And last one is the culture. Culture takes like 14 weeks to like 20 weeks to come, so it's a long time. By then, if we don't treat the patient, already it would be a, like, it would have gone for secondary tuberculosis or some, not secondary, like miliary tuberculosis. So we need to treat. So these are the various methods by which we diagnose. Currently in practice, what we do, okay, currently for tuberculosis, the diagnosis what we are, ऊपर बैठो, उसके ऊपर बैठो, we do is one is this Montauk's test, the skin test, and second is we send the culture, like in here and all, we do this gene expert test. But for the low, economic, socioeconomic status, it's a bit difficult. Okay. So there are some other important terms which is not required because I've already told. Okay. Now this one you are supposed to know. Non-tubercular. If it is Mycobacterium tuberculosis, it's different, but there are some non-tubercular Mycobacterium species also. They present the same way. They present with the granulomas, but the clinical symptoms might not be the same. They may not have sputum, they may not produce sputum and all that, but still you have to just know because these organisms have a different treatment than the regular AKT program. We have to add some additional drugs apart from rifampicin and all that thing, so we need to know this. And again, how they are diagnosed? They are diagnosed by this gene testing or the culture methods. So these non-tubercular Mycobacterium will not affect regular people like us. These are again the people who are a bit immunocompromised. So in what cases? One is where there is already some structural lung damage, like somebody who has got up from the ventilator, the lung is damaged, or somebody with an infantile or childhood birth disorder of ciliary immobility, or somebody who is immunocompromised, somebody who has a pacemaker or something inside him, any prosthetic device. So all these bit of immunocompromised people, not in regular people, will get to see this. Okay, so that's all you're supposed to know. And one thing which is addition in this is, in patients with AIDS, there is no immunity, as I told you, or in other patients who are immunocompromised. But usually HIV-associated tuberculosis is a question which is asked commonly. So in that, don't write about granulomas, because there is no immunity. So granuloma cannot be formed in that. Okay? Granuloma is a sign of a healthy individual. It will be there only when there is immunity. So any person who is immunocompromised will not develop granulomas. Okay? So in HIV-associated TB, just write the symptoms, write the gross appearance, and write in the microscopy granulomas are not well defined or not well formed. Like that, you can just mention. Okay? Fine. So this is the last bit of it, I guess. It's just an algorithm. I have put it from the clinical point of view. It's right now nobody is going to ask you this huge thing, but you're just supposed to know it because I'm telling you invariably you will come in contact of TB. If some of you are taking this respiratory medicine because it's a new branch and in the borderline seat numbers you get it easily, and it's a very good branch actually, and subject, you need not study more. So there you will be seeing these kind of things regularly, so you should be aware. It shows a lot of things, but the overall take home message of this flowchart is, Anyone you are suspecting of TB, like a person with a chronic cough with sputum from 3 weeks, you have ruled out bronchitis, you have ruled out bronchial asthma, then you do a sputum test. You send for sputum culture. So you have to do 3 sputum cultures. Okay. First time it might come negative, but next and next to next time if it comes positive, then you are suspecting TB. Then you immediately do the skin test. You do the genetic test. If it is positive, you start the this thing AKT. AKT is nothing but antitubercular regimen. Okay. So that is all it is about TB. Read TB. Okay. It will be one of the questions.